Good afternoon, everybody, and welcome to today's meeting of the Health and Wellbeing Board at the London Borough of Hillingdon. The meeting is being broadcast on the Council's YouTube channel, Hillingdon London, and my name is Keith Spencer, and I'm the co-chair of this board. As is usual, there's some housekeeping just before we start. Can you please ensure any mobile phones you have are on silent? I forgot for the last meetings, which is not great from the chair's point of view. We're also not expecting a fire drill, so if the alarm does go off, please follow officers out of the building. And again, we always get reminded, but we forget, I think, is please keep your microphone muted when you're not speaking, and then unmute to speak. And it is worth noting that some members of the board may be using devices to access the agenda and papers for the meeting. This is normal, so please understand. Okay, can we move on to the agenda? Apologies for absence. I think I've got 2 or 3 notes first, just to read out. Sam Norshin will be attending on behalf of Health Watch Hillingdon, so your voice for the time being. It's good to welcome Sharon Stoltz, who's been appointed as the Council's new Director of Public Health. You're very welcome, Sharon. And then some sad news, I think we've got to report. I think Derval, is this your last meeting with us?
It is indeed. I've taken on a new role across all of Guys and St Thomas's covering 4 so unfortunately I won't be attending anymore, but Richard Mason, the Chief Executive Officer for HLCC, will be attending more.
Thank you for that, Derval. And I think when we get to the main agenda item, we could minute our gratitude, Nikki, to Derval, who's been a stalwart of this committee over many years. And thank you for your contribution on that front. So, Nikki, do we have any apologies?
Chair, we've had apologies from Professor Goodman, from Councillor O'Brien, from Vanessa Odlin, and Claire Eves is here as her substitute. From Julie Kelly, from Leslie Watts, and Alan McLennan is here as her substitute, and from Sam Norshin.
Thank you and welcome, Alan. I think this is your first Health and Wellbeing board. So if I just move on to declarations of interest in matters before this meeting. So other than those already declared on the register of interest, do any members present have any declarations of interest on any matters being discussed today? I'll take silence as no. And then, if I may, I'll move on to the minutes of the meeting on the 9th of September 2025. I am not going to read through page by page. Does anyone have any comments on the accuracy of the minutes? If not, can I take these as being agreed? Okay, thank you. And then I'll move to exclusion of press in public. I can confirm that items 5 to 11 will be considered in public, and items 12 to 14 will be considered in private. Okay, so I'm now going to move us on, if that is okay, to agenda item number 5, the Integrated Health and Wellbeing Performance Report and Service Update. And I think, Sean, you're going to lead on this, supported by Gary where necessary and relevant. Sean.
Thank you. So I'm going to present the Health and Wellbeing and Performance Reports. Although I do appreciate there's quite a lot of information in there. So what I will do is I'll start by taking the report as read. However, I will run through and highlight the key points or messages from within the document to give an overview and highlight the sections as I'm going. So if you want to refer to where I am in the document, and then happy to take any questions at the end. So to start by summarising, if I look at the board priorities overview and executive summary, the report overall tracks progress against our 5 strategic priorities, which is the best start in life, live well, age well, healthy places, and equity and inclusion. And our focus for the first 2 years has been on live well, age well, and equity and inclusion, given the impact on urgent and unplanned care. The 3 key areas that we're reporting on within the report is the integrated neighbourhood teams, the reactive care programme, and the best start in life. And a few of the key messages that I would have within there is to pull out is the emergency demand remains high, with A&E attendances averaging 171 per day, which is slightly above the target, although we have improved from last winter. We are seeing some early signs of improved hospital flow, notably with a 27% reduction in no criteria to reside delays. And all 3 integrated neighbourhoods are fully operational, which then supports the provision and foundation of proactive community care, and we have frailty management is reducing admissions. Overall, we have hypertension outcomes are strong. We have our prevalence around 13.8%, and 77% of those known patients are achieving blood pressure control, and this is one of the best rates we have within North West London. And then within the reactive care model is starting to mature, and then within Best Start in Life programme is starting to progress, especially in mental health support in schools. However, I will just say that we do have challenges that remain, and that is the high A&E demand is sustaining the improvements that we've already implemented, the growth that we are seeing in long-term conditions, and some of the neurodevelopmental demand within children, and winter pressures that are either here or could be yet to come. So if I move on to the neighbourhood section, within neighbourhoods we've got the integrated neighbourhood teams, and they are the core delivery for Hillingdon's Live Well and Age Well priorities, and each neighbourhood brings together GPs, community services, social care, mental health and the voluntary sector into a single team focused on prevention, early intervention and personalised care. A few of the key points from within there are we are seeing frailty case management is progressing well. We're covering around 50% of the severe frailty cohort are now under enhanced management, and that has contributed to around a 36% reduction in emergency admissions in relation to those patients. Our hypertension case finding, as I've mentioned, is at 13.8% prevalence and a 77% control rate. We've seen some targeted outreach in reducing inequalities within the community outreach for areas of high needs, and we've seen some NHS health checks have proactively reached 350 high-risk residents and given them the support that they require. Our primary care networks overall are delivering enhanced services which strengthens the prevention and long-term condition management, and some of the outcomes from the Pharmacy First has become a major access route for supporting minor illnesses, with over 18,000 consultations being supported in the last 6 months. We've also seen some movement in dental access, and we've seen some improvements there, especially for children and vulnerable groups, with pilots in place to support with oral health and inclusion. Some of the forward plan for neighbourhoods that we're looking for is fully expanding frailty and the anticipatory care coverage by April 26 to full coverage of that. Implementing the borough-wide hypertension strategy so we can actually be on target to hit the 16% by March. Strengthening the mental health integration with integrated neighbourhood teams to bring that element in stronger. And then bringing in some more lower-level neighbourhood performance dashboards so we can actually map, track and see how we're progressing at a lower level to support there. If I move on to reactive care, the reactive care programme obviously strengthens urgent and crisis response in the community, so our residents can receive the right care at the right time in the right place. And we have a number of schemes there that are bringing everything together from urgent community response, discharge pathways, all into a single coordinated model with a simplified referral route via the new coordination hub. We are looking for the coordination hub to launch this month, so in December, and that will provide that single point of access for urgent community referrals. We now have mobile diagnostics. It's initially providing x-rays for housebound and frail patients, and that is live, and the service is being constantly reviewed to ensure that we're maximising the benefits that this service can bring. It is on an initial 6-month pilot, and we're monitoring that as we progress through. We have our urgent community response service, which offers a 2-hour response, and we are looking to expand the staff in place there from the new year, and we already now have senior clinical decision makers in place, providing strengthened decision making for complex cases to support with earlier discharge or admission avoidance. We have the Lighthouse Mental Health Crisis Service has been expanded, and the new operating model is live, and this provides an alternative to ED for residents experiencing mental health crisis. And then there's been lots of work on a discharge pathway in relation to no criteria to reside, and these are patients that basically are medically optimised and don't need to be in hospital, and we need to support those out. We averaged around 48 per day, and since we've been running this joint NHS local authority target plan, we've kind of got down to around 35 per day now within the first three weeks there. I probably would just caveat and say over the last 2 weeks we have seen an increase in demand and pressure, but with these new ways of working we've been able to ensure the processes are working as smoothly and efficient as possible, but having the right escalation processes in place so we can sort of support with any of their concerns earlier in the process and make sure we've got the most suitable people or teams or partners in place to support that when we're at times of pressure. A couple of the forward plan pieces for reactive care. So as I've said, it's mobilising the coordination hub and looking to expand the lighthouse capacity further. We're currently at, I think it's 6, and we're looking to move towards 10 once we've reviewed that. Launching an integrated rehab and reablement service. Initially that was sort of soft launch this month, then further embedded from January. And one of the big ones is sustaining the delayed discharges and the work that we've been seeing to sort of sustain that and support that at around 34 per day. I'll just do a brief update for Best Start in Life, and then I'll go on to any questions. So Best Start in Life, the programme aims to ensure every child has a healthy, safe start, focusing on early identification, integrated services, prevention and reducing inequalities. Some of the progress includes developing child health hubs, expanding the mental health support in schools to 80%, and halving the neurodevelopmental assessment and backlog. Some of the new children and young people dashboards that we're looking to put in place will consolidate all the key metrics and support targeted action. And the priorities that we have up till March 26 is launching that dashboard, prototyping a child health hub, enhancing the community paediatric service, and strengthening links with family hubs and early years service. You will see some further appendices around there that highlight some of the investments that have been made locally that support some of the things that we've gone through. I will probably pause there and ask if there's any questions anyone would like to ask.
Thank you, Sean. So obviously we're now right in the middle of rolling out the transformation work that we've been talking about for about 18 months to 2 years, and we've chosen to do it into the teeth of winter. But again, any questions for Sean on this issue?
Thank you, Chair. Not a question, Chair, more a comment really around the hypertension target. So it's noted in the report that one of the actions that we're planning to undertake to increase that target is a campaign, a borough-wide campaign. That work has started. We plan to run it in a February to on the back of the British Heart Foundation Heart Month, so that we'll get more bang for our buck, if you like, by doing it on the back of the British Heart Foundation work. We're also planning to link it into the Pan-London programme around healthy hearts, and it will be a borough-wide campaign run jointly with the Confederation, but also the Council and the public health teams and the communications team in the Council are already meeting to plan this. So I just wanted to make the board aware of that. An important part, I think, of this campaign will be around what happens after someone has had their blood pressure taken. It's more than just knowing your numbers. And even though a proportion of people with high blood pressure will then be referred into primary care to have their blood pressure managed, the majority of people will probably find that their blood pressure doesn't require that onward referral. So for me, there's an important education element here. about the health promotion information and the messages that we can give to people around how they can self-care, self-manage, what high blood pressure means, the kind of small changes they can make to their lifestyle around diet, physical activity, etc. And also encourage those that can to monitor their blood pressure themselves at home. You can actually buy blood pressure machines quite cheaply now, but also educate people on the risk factors and when they might need to go to see their GP, for example. So this isn't about swamping primary care with all of these individuals who will have had their blood pressure taken. The campaign is part of a whole systems approach. But as I say, an important element of that is how we actually educate people to keep themselves healthy and well. Thank you.
Thank you, Sharon, for that. Jane, do you want to come in then? We'll come back to Amanda.
Thank you, Keith. Yes, I'm pleased to hear that we'll be doing that. And I was actually in the library myself at the weekend doing my surgery, and we've got a blood pressure monitor in there. So I'm very keen, excuse me, very keen that your conversation there, Sharon, about what we're doing afterwards was quite important to me, because there were 3 people there who had their blood pressure taken. 2 was okay and 1 was not. And I sort of walked away thinking, what's happening there? What is that person going to do? So I think what I'd like to see when we roll that out is information. I mean, I'm sure it says somewhere, if it's this, seek your GP's advice, but being somewhere where it's not always able to see a GP's advice, and I speak from my own personal experience, I would hope that when we do the campaign, we put some literature out so that residents aren't left with fear at the end of the reading. Thank you, Keith.
Amanda.
Yeah, just to support what both Sharon and Councillor Palmer have said. Yeah, very excited about doing a big push actually in February. I mean, obviously there are many other things that we're doing in the meantime, as you know, Sharon, continuing the outreach work that we do in collaboration with CNWL and voluntary sector partners, and trying to make every contact count in every place. But completely agree with Councillor Palmer, and whilst it's completely correct that you can buy blood pressure monitors relatively cheaply, lots of people still wouldn't be able to do that. So actually signposting them to go regularly, perhaps to a pharmacy or to another location. The advantage, of course, of a pharmacy is that there will be a proper pathway to make sure that that person linked in if their blood pressure was out of range, even if the reading doesn't go directly to the GP surgery. And also, whilst I appreciate the comment about not swamping our practices, we really want to know people's readings, even if they're perfectly normal. Actually, having good data is key to making sure that we get to the right individuals, the right groups in the right places. So, we are all joined up on it, aren't we? So, hopefully we can make the big push. It's still a big push, though, to get from just under 14% to hopefully towards the 16% in the timescales that we've indicated, but we're going to do everything we can to make that happen.
I'm going to go to Gary and then I'll come to you, Tony.
Just to say, Chair, that the intention from the next report is to include reporting on the 3 national metrics that we're required to report on under the Better Care Fund. So that's emergency admissions for people aged 65 and over, discharge delays and permanent admissions to care homes for people aged 65 and over as well, so that the board can see on a regular basis our performance against those metrics, which are likely to carry forward into 26-27.
Thank you, Gary. Tony?
Thanks. I think I've got the makings of a question, but it's going to start life as a philosophical musing, I think. To separate ones, if that's okay. So the first one is, but first of all, well delivered, Sean, really well done. I think we need to start focusing more on the application of the transformation that you mentioned against what the baselines would be if we hadn't done the transformation, if that makes sense. So things in themselves, fine, I know how many of this and how many of that and how many of the other. What I don't know is what's the impact on the systems prior to those things being in place, and has it stopped people rocking up at GP surgeries or the hospital front door or whatever. So I think we probably just need to think a little bit about how intelligently we focus on, rather than just there's been this many of this, actually how against the transformation ambitions that we have those things worked. And obviously as we get closer to a new hospital, that's going to become a more important point because it's predicated on all these things being there. So is the one point, and you'll be delighted to hear that the second one's left my mind. So I'll leave it there.
We'll let you come back, and I think what we've done, and I agree to Sean, that was well presented, and I think we've got better handle on the metrics on this one. The metrics we're measuring against are the metrics that Alan will recognise in the new hospital programme. So when we say, why is 34 a magic number for no criteria to reside? Because that's the number that's in the hospital redevelopment programme, and our previous numbers were close to 60 on that. So you're right, Tony, and I think what we're trying to do is measure it all the time against the benchmark of a new hospital. Because if I go and talk, as I will do on Thursday evening, to the governors at Hillingdon Hospital, we're all using the same numbers, so they recognise those numbers. So I think you're right, that's the important point.
So great, but if I'm a resident, I'm not sure I would understand that from what I've heard. You know, just in terms of like this, so straightforwardly, what was it then? What will it be? And show me how what you've just said is the journey from that point to the other. And the other point that left my mind and has come back was and a little bit sort of to Councillor Palmer's point really, was the we've spoken a number of times, we may not use the term, but we've spoken about kind of health literacy and I suppose I mean like system literacy, if you like, and there are so many blinking notifications of things, do this, do that, do the other. Trying to know what actually the straight line through the system is pretty tricky, and we probably, and with all of these kind of initiatives all called different things, and it's not the same. I don't live in the borough, and I was at my GP surgery the other week and thought the same thing. I was sitting looking at a notice board, thought, good God, I have no idea what to do. There's about 1,000 different things I could do, but I'd have no idea which one would be the most optimum for how I'm sort of feeling. But so I think there is definitely something alongside all of the other things we're doing as a part of the transformation to then think about, almost like how we draw a line across what is communicated to people about what the pathways are for doing things, and actually almost redefine them so this is now how this works, because we just compound and build on top of. So just another point.
No, completely agree on that, and I think that the simplification is really important. I think, Tony, you're absolutely right.
Yeah, I think that point in the middle there was the one that you and I have been conversing about. So my experience of today was in the new hospital programme, we've been given a big task of what are the transformational needs that you're going to highlight and give some detail of in a £1.4 billion business case. So it'll get crawled all over by Treasury. And where we got to, and the advice that we were given, was a series of metrics. And I was asked the question of how much time and money was I going to need to produce that. And 60% of it, I knew where it was coming from. You know, I knew that you had a document, I knew that you had multiple documents, and some of the things that we've been working on about the primary health, public health, already fed into it, which makes me realise we are very joined up in what Place is doing, what Confed is doing, what we're doing. And I think what's really missing is, what does this add up to the person who lives in Hillingdon? So me and my wife live in the borough, she's a GP, I run a hospital, and I find it difficult to navigate it. And there's navigating it and knowing what it is that we are up to. And these are two bits of communication that I think that we've we're missing out on. We went on Friday to a really good event ran by Danny Beals about health and his constituents, and it was clear to us the paucity of knowledge of what it is that we're trying to do. Nobody in that room really had a sense of what we were doing about public health. They were aware of the hospital, but only because it's either going to be invisible and not happen, or a white elephant. Those are the only two choices that seem to exist. And the idea of what the hubs were going to provide and how they were going to do that was missing. And I think you and I and Amanda, we're really close to being able to sort of describe it fully. But after that, it's got to be described properly to people of Hillingdon, but also their place in it. We are expecting you to do this. We're expecting this is how you prevent frailty. This is non-smoking. This is etc. etc. Thanks.
Thanks, Alan. I completely agree with that. And I think when we come to talk about health and wellbeing strategy, putting that into a language which human beings understand is going to be quite important. And we need to stop thinking. I mean, we could probably all recite the language in this in this document, but when you speak plain English, I found on Friday evening, when you speak plain English to people and tell them what you're trying to do, they buy into it. They buy into it. They understand intuitively. Right. And if we articulate the whole picture, then actually people understand what you're trying to do. The risk is we end up in just point discussions, don't we, about minor injuries units, and in the absence of the big picture, it just looks like it's a reductionist policy. So I think articulating this with our community is the most important thing that we can now do, and help put it into plain English helps us actually articulate it better. So I completely agree, and that's been a learning point. Certainly talking to the public, it's been a real learning point. You explain it in English, people see how what we're doing could be game changing for them. We've just got to implement it. I mean, I think the thing I will want to talk about at some point as well is we're at the foothills of this transformation programme. To get all of this over the line requires significant capability and significant capacity, which I think we'll have to ask ourselves whether we think we've got that in terms of doing it. And I think that is an issue for us to give some reflection to. I just wonder whether it's worthwhile for the record is just obviously there's a lot of interest in the neighbourhood hubs. A huge amount of public interest in the neighbourhood hubs. As you can imagine, you put a building somewhere, and actually it is a focal point. There is a real interest, both politically and locally, in the neighbourhood hubs. Where we are at the moment, and there's discussions going on actively, is we're currently developing a business case for the 3 hubs. We anticipate having that in full done by the end of March. And we're preparing a business case on the basis that it'll have to satisfy a number of masters in terms of getting this across the line. But I just wanted to clarify for the record that being part of the National Neighbourhood programme is we're part of the model of neighbourhood services. As of yet, there is no funding, either revenue or capital, coming to the 3 neighbourhood hubs. And what we're doing locally is looking at what our options are in terms of what the funding of those neighbourhood hubs. And I think it's just important for public listening on to understand that's where we are. And I do believe some of the stuff that we're doing, I think, Alan, the work we've done to date on discharge, I think for the first time in my living memory, we've got a clear and joined up view of the challenges that we've got, which I think hasn't always been the case. I mean, we know what we need to do to fix it, I think, but some remarkable work going on in the hospital and in place to manage that. And then I don't understand, I don't want to put you on the spot, but I am not going to put you on the spot. I think there's some exciting work. I can remember talking to Tony Zaman about rehabilitation, re-ailment about 6 or 7 years ago. But I think we are trying now to integrate that and to have. And did you want to say what the thinking is and the timeline is on that kind of thing? Sorry. You need to hold people to account, Tony. You know.
Yes, the reactive care programme is making progress and becoming reactive, and we're working towards an integrated service. That means that people's discharge from hospital, which includes therapies, and we're working closely with our partners to join up so that the council's delivering from the hospital front door onwards into reablement to ensure swift discharge with the level of support that they need very quickly to ensure that the numbers of no criteria to reside stay below that 34 magic number, and that people aren't in hospital longer than they need to be, which is obviously our priority. And if they get the therapies that they need into the community, and if you talk to colleagues, everybody will say we need to sharpen and improve our therapies model, so that's something that we're concentrating on. It goes right across the spectrum, so from all adults, including those with mental health, and the direction of travel for those and where they are best seen in the community so that they don't end up in A&E and spending long periods of time in hospital also. So the next steps will be the integration of a couple of teams into the discharge processes which are for rehabilitation. I'm not going to name them because it starts to make, we need a new name for the process of those teams. At the moment you've got a range of services that are provided to people when they're leaving hospital to enable them to do so quickly, and we will be doing that but in a much more integrated way.
Anything to add, Claire? I like putting people on the spot, actually. It's good fun, isn't it? Yeah.
Thanks, Keith. Yeah, Sandra, just absolutely agree that we have to build on further questions been raised here around how we build on and add on to existing services, and that has just absolutely got confused people who don't know where to refer. We need to streamline these, make it one linear, as you said, Tony, linear referral through a pathway which patients can just come into a service and exit and receive the care that they require. So CNWL are working with local authorities to make sure that that happens in the time frame that we have stipulated. Thank you.
Okay. Any other questions before I move us on? So I think if we can accept the report, the action I would like to add is that if we can have a conversation about that transformation capacity and capability and execution, which I think is the issue here. I just think we do need to have a conversation, particularly in the light of changes to the ICB, I think, going forward, which I know we'll talk about in part B, but it is a concern to me as we look at the scale of the challenge that we are facing. Okay, if people are happy to accept the role, thank you, Sean, for that. You can come back. Can we move on to the Joint Health and Wellbeing Strategy? Gary, are you going to present this? Sorry? Yeah. The look of panic on your face there is I don't want to. Would you like me to talk to it? Yeah, and maybe Sharon, you can support on this, just to prove my versatility and ability to talk to many things on the agenda.
A bit of modesty.
Yeah. Yeah. So our existing health and wellbeing strategy, I think, has run out. We are statutorily obliged to have a health and wellbeing strategy, and we had a discussion earlier in the year, I think, about some health and wellbeing priorities. So what this document is intended to do is not to boil the ocean. Is an attempt to focus on those interventions across the life course which have demonstrably some evidence of moving the health and well-being of the population. It's made up of two parts: the what, which are the priorities and the metrics, and the how, which is the place operating model. And the place operating model we have discussed now on multiple occasions. So what we've done is just connected together, if you like, what needs to improve and what is our target in terms of the health and well-being of the population, and how we're going to deliver that through our place operating model. So the strategy sets out a shared vision for a fairer, healthier and more integrated Hillingdon. It's structured across the 4 life course outcomes: best start in life, live well, age well and healthy places. And each section sets out a small number of priorities with some clear outcome measures and action partners will take collectively. And what we've identified, and this will come as no surprise to us, are 7 high impact programmes, and they're the programmes we've been speaking about now for the last 12 to 18 months. And as far as we are aware, and I'm sure Sharon will correct me, and I'm grateful for Sharon's review of this as she just joined post, we'll try to focus on things which are known to work or have a chance of working, and not set targets for ourselves which A, we can't measure, and B, we couldn't demonstrate effectiveness against. So try and keep those small. So delivering the strategy will require service to be organised differently, and the operating model sets out how partners will work together to deliver care through 3 integrated neighbourhood teams aligned to primary care. You are familiar with that. We made the link in this document now to the family hubs, and our operating model, there'll be a relationship between family hubs and neighbourhoods, because that is the government's framework for doing that. A borough-wide reactive care service, and of course a new Hillingdon hospital. And what the integrated neighbourhood model does is enable early intervention, reduce avoidable hospital attendance admissions, shortens length of stay, and promotes independence and wellbeing in the community. What I would like to do is to use, it's going back to the point Alan and Tony made in the previous agenda item, I'd like to use a plain English version of this document as a primary vehicle for engagement with our residents, with service users, carers, voluntary and community partners through January and February, because the challenge we're having at the moment is we're being reactive, is people are inviting us to come and talk about what we're doing, and it's nearly always in relation to the new hospital, and what we need to do is to set out what our plan is for health and wellbeing in Hillingdon in a much more coherent and joined up way, so that we can set the hospital in its right place, which is a part of a wider offering. The bit I would want to flag here in terms of the metrics, these metrics, Sean already collect most of those metrics in the performance report that you've had today, so we've already done quite a bit of that work, and it gives us the opportunity to capture some longitudinal change. I think at the last meeting we had a request to bring children and families into that, and we brought that very firmly into the document. I'd give 2 caveats to that, and 2 challenges, I think, and Sharon was on the receiving end of my resistance to adding more priorities. I'm a great believer, the more priorities we have, the less chance of doing them we're going to have. And my challenge will be, if we're going to take on children and young people as a priority, we have to resource it. We have to resource it to succeed to do that. And I would look to the local authority as the lead on children and young people in terms of leading that process. It would also be good, and Tony will kill me for saying this, it would also be good to have the Director of Children's Services at the Health and Wellbeing board if we're going to have a priority, which is on children and young people. I think that's quite an important thing to do. And then the other thing is simply to say, we'll monitor this, we will, but we need to engage with our public and our residents on this. And again, that should be, we do the heavy lifting in January and February, and bring it back to the board, I think, towards the end of March, recognising that we have local elections in May and PERDA and all that sort of thing takes in place. But I just think we need the opportunity to engage with our public, and I didn't want it to wait. If we pushed it any longer, it'd be the end of the year before we'd be having these conversations. So I'll hopefully it's an easy read. It's not Harry Potter, but then again, it's a dry subject. But I think it's an important subject, and it has enough in there for what we for what we need to do. And I have to say, I learned something not in part of this. So I will pause there. Again, what I'm asking the board to do today is to approve this as a basis for engagement, on the base that it will come back to the board towards the end of March with a definitive strategy, having engaged with our residents and the groups that we need to engage with. Have I missed anything, Gary?
Just that the point about the consultation period. So the next meeting of the board is actually scheduled for the 3rd of March. So the recommendation that the meeting of the board actually be pushed back to the 24th, which will actually then give a bit more time to undertake the consultation process.
I'm going to look at Nikki. Is that something we need to review?
Chair, in terms of having a new date, it's something that we can resolve, and then, yeah, I can just do it.
Thank you. Sharon, is there anything you want to add as our Director of Public Health and helping steer this document to safe waters?
Thank you, Chair. It is a very ambitious strategy, I think. I'm really pleased to see a focus on maternity services and children. We can't deliver improvements for our population of Hillingdon unless we start doing pregnancy. There's a whole load of research evidence around the importance of what's called the 1001 days, which is from the moment of conception to age 2. And that is reflected within here, which I'm really pleased to see. If we deliver everything that we've got in here, then we should definitely see the improvements that we all want to see in the health and well-being of the people of Hillingdon, but also reduce some of the pressures on our services, which is obviously a golden thread running through this as well. I have been having some conversations with colleagues in CNWL. Haven't yet had an opportunity to have a conversation with the Children's Services Director, but I will do, about how we strategically lead the work around the child health agenda here. We have the Safeguarding Children's Partnership, a very robust partnership, but understandably much of the focus in here is going to be on public health related issues, maternity services, breastfeeding, smoking and pregnancy, maternal obesity, childhood obesity. Those priorities don't currently sit with the Safeguarding Children's Partnership. So we do just need to think about the governance arrangements, really, I suppose, about how we deliver on this for children. And we've started having those conversations. I don't know, Claire, if you want to add anything around that. Thank you, Chair.
Thank you, Sharon. Yes, so we, as you say, we've met last week and identified that there needs to be stronger relationships between, our colleagues in the local authority and ourselves in CNWL, and we welcome that. We see that CYP has not necessarily been the forefront of our conversations, and I'm really pleased that we note it here, and I really think we need a strong strategic direction, a group of directors that can take that forward and really get the voice of CYP onto the page, and I welcome that this is reflected in the strategy. Thank you.
I'll be disappointed, Tony Zane, had you not had anything to say on this.
I do have some things to say about it. And again, it's more of a reflection point, really, on whether we are sufficiently brave as a system, a place, to be slightly more, I was going to say egalitarian in our approach to, and actually think of it more of a kind of social contract type point, and how we are not, and I think Alan may have alluded to it earlier, but where, yes, we are doing all of these things, but we expect that, you are doing some of these things, which is about the kind of self-help, self-care, rather than we start from the point of people have got to a point where we put a whole range of things around them in order to support them and develop them from that point in time, accepting the all of the range of things that we can do from a public health point of view. Absolutely, yes, they're there. All of the things about sort of the better start in life, all of those sorts of things, yep, absolutely. But then there are things when, if you like, as children through schools are sort of growing up, and parents, and again we mentioned that sort of earlier, but it's what's our expectation of the population looking after themselves, and how we, and I'm not saying that's an easy message to give, and obviously it comes with some challenges, particularly from working in a political organisation, but nonetheless I think it is something to think about, whether we actually do put some of those messages in what we're doing. This is not just, there is a point at which the elasticity of the system gets to a point where something's going to have to give, and people have a part of contributing something towards not reaching that point. Not just we find ways of making resources go further, which of course we'll keep trying to do, but just there's probably a bravery point, because otherwise everyone's a passive recipient of something and can just go along doing whatever, and it'll be fixed. Well, unfortunately we're out of time on that, I think.
That's a really good point, and I will come back to that, but Jane, do you want to come in?
Please. I just wanted to say that I think it's essential that what we're doing around the table, we must have some representation from children's services. When we're talking about children's health, I'm going to raise the issue of domestic abuse and how many children actually witness it. And Sharon's just spoken about the first 1,000 and whatever it is days, and in that will be children that have witnessed domestic abuse. And I just think it's something that we need to bear in mind here. We don't really talk about it much, but one thing for sure is that is not on the decrease. It is not stopping any time soon, and I see no sign of it. And we can't look at any resident's health without taking that in mind, whether it's the physical aspect or the mental aspect or the silent abuse. We have to talk about it. So I think it's essential that when we're looking at any part of health, we have all the relevant people around the table. Otherwise, we're going to go back to my pet hate of gaps. And with gaps, you don't get excellent services. And we've worked really hard in this borough and around this table to do a lot of really, really good working with our health partners. So thank you, Chair, for that opportunity, but I feel very strongly about that as it's part of my portfolio too.
Thank you, Jane. I think it's a point really, really well made. That I think what we might need to reflect on, I think, Tony, and again, I'm going back to some of us who on a weekly, daily basis wrestle with a discharge issue, where actually I think we need to encourage the people we said to take more responsibility for what they do, and this is my phrase, not anybody's phrase around the table. If I take the discharge issue, we are gold plating some of the things that we are doing, and it's not health responsibility to sort people's lives out. It's not social care either. So, and I think from that perspective, you're right. There's a challenge inherent in this as we go forward about what we can reasonably be expected to do. Given people's responsibilities. I think that is going to be a challenge, a real challenge for us, I think, going forward. Any other comments or observations people want to make on this one? So, can I ask that we, if the board is minded to support the health and wellbeing strategy as fit for purpose for engagement on the basis of plain English and we won't send this version as it stands, but it's got your approval in principle to move to engagement. I'll take that as a yes. Thank you very much. I'm sorry for landing on you, Gary, in a I'm sure you can cope with it. Right, I mean, actually, whoever structured this agenda this way, well done, it's structured really, really well, because we're now moving on to the child health obesity update, given what we've just spoken about. Sharon, are you going to take us through this?
Yes, thank you, Chair. So this report is primarily an update report. I think the Health and Wellbeing Board requested an update on the work that is happening across the borough on childhood, the management of children's healthy weight. I've took the opportunity in the report just to remind ourselves of why tackling excess weight in children is so important, because we know that excess weight in childhood so often leads to excess weight in adulthood and the associated long-term conditions that are linked to that. Indeed, page 9 in the report, figure 3, actually has got a table that shows the percentage of long-term conditions and that are attributed to obesity. I think most of us know about diabetes and hypertension, but there are a number of other long-term conditions listed there that perhaps aren't as well known as being linked to excess weight, including gout, various cancers, including ovarian cancer, osteoarthritis, etc. So the drive to tackle excess weight in children really needs to be at the top of our agenda. So the report then highlights some of the work that is already going on, and as you can see through the report, there are a whole range of activities that are going on. What for me, though, being new to Hillingdon, and I'm happy to be challenged on this if my assessment is not right. I've only been here a short while, but we don't seem to have any clear strategic direction for tackling excess weight in Hillingdon, and children do not live in isolation. They live in families, they live in communities. Children don't buy the food, they don't cook the food, they don't decide what they're going to eat. Neither do children decide how physically active they're going to be, whether they're going to be outside playing. Children live in families and in communities. So what we need is a strategic whole system approach to tackling the issue of excess weight in Hillingdon, I would suggest. So the report is here for information, primarily, but I suppose I'd be interested to hear board members' views. I saw a couple of nods when I said that to me we don't seem to have a strategic approach to tackling excess weight in Hillingdon. The fact that I can see nods means that other board members probably support that view. And so, to me, what perhaps needs to be an action from this report is for myself as Director of Public Health to therefore lead a strategic approach across Hillingdon. I'm not a great fan of strategies for the sake of strategies. They're documents that end up, cluttering up our online record systems. But we certainly need a strategic vision. We need a whole system delivery plan. So I would like to suggest, Chair, that maybe an agenda item around that strategic approach to excess weight, all ages, could perhaps be included in the delivery plan for the Health and Wellbeing Board, and that's something that I could bring forward at some future date. Thank you.
Thank you, Sharon. So I will have a question, but I'm glad you said that, because I wrote, when I was reading my papers this morning, I wrote, this is a collection of projects, not a strategic system-wide programme. So I'm just relieved you said it, rather than I. So I would completely support that, and I think given we've just discussed the health and wellbeing strategy, of which this is a key component, you're absolutely right, and action has to be, what is our strategy in relation to this in the context of the health and wellbeing plan, and it goes into our delivery plan as a part of that. So I would support that. Comments from people round the table, observations. Councillor Palmer.
The word hallelujah comes to mind for me. And I'm more or less sure, although I don't speak for my colleague, Councillor O'Brien, she would be saying exactly the same thing. We've both sat here for a long time thinking, yeah, we keep talking about it, but what's happening? So it has my full support. I think it's something we really need to crack on with now. We've talked about it long enough. We all know it needs to be done. How are we going to do it? Because it's not getting any easier. People being stuck on their phones, not just children, but if we can see an end, and also for the children and for the residents, once again, they need to be brought on board with this. And I say this quite a lot, that I don't think that is something we do to the best of our ability. I do think that this council could do a lot more to engage our residents and bringing them with us, rather than having to try to explain to them after what we've done. So this is welcome, Sharon, and thank you, and hallelujah too.
Yeah, very welcome. Completely agree with comments made. And I just wanted to add to that, Sharon. Colleagues in primary care would want me to remind you, and I'm sure you don't need reminding, that we need to think about our very diverse populations. We have it's very difficult to reach some populations in the way perhaps that we think we could do in the past, and actually reflecting that, engaging with those communities is going to be key to making that happen. It affects vaccination rates and other screening programs, and this will be exactly the same.
Thank you. Alan.
Yeah, two comments. Very supportive of this. The first is, I think it does tie into what we were saying earlier on, which is, can we crisp up the expectations of people who live in Hillingdon, that this is an everybody's problem rather than our problem. And the second thing is the diagram on page 10 shows the inequality here. We drive this, then we narrow the inequality gap that we kind of wring our hands about, and actually this would really make a difference. Thanks.
Devil.
Hi Sharon, very supportive as well. I particularly liked your emphasis on the fact that a child's obesity is very much linked to the family and what the family do and what the family eat and what activities they do. I just wondered, when we looked at that graph that you talked about on page 9, some of those things are actually in our priority list for our strategy. Should we therefore be looking at doing more to focus family health and family weight loss instead of trying to separate them into adults and children?
I think that the neighbourhood approach that is a key part of what we're trying to achieve through the strategy will help us to do that, particularly the discussions around how we link the family hub work much more closely into the work of the integrated neighbourhood teams. Some things lend themselves to a whole family approach, And I think excess weight is definitely one of those, because obesity is such a complex issue. It's cultural, as Amanda has already pointed out. But our attitudes towards food and physical activity are deep-rooted and intergenerational, which is why we need a different approach. I'm not sure you could necessarily use that approach for everything, but if we get this right for children, you get it right for adults, because you can't work with a child in isolation. You have to work with a family. You have to work with the extended family in some cultures. So it's why I push Keith so hard to include children in the health and wellbeing strategy, because if we get it right for children, we're much more likely to get it right for adults. But ultimately, it's about working with people, as Tony said earlier. It is about health literacy. It's about how we engage our communities. So the health and wellbeing strategy will, I think, certainly take us in that direction. And then we can use the work on excess weight as a vehicle to start introducing other areas that we might want to focus on as well. But if we address the issues that lead to excess weight in children, we'll reduce hypertension in adults. So you can see how it actually becomes linear. But we won't necessarily see the improvements in our adult data for another generation. So the work we're doing now with children, you may not see the results of that in the data for adults for another 20, 30 years, but the evidence is there, and the health economic argument is there, that we will actually see those changes. But you kind of have to have a little bit of faith that you'll see those changes, because we may not be here in 20, 30 years' time to look at that adult's data.
I think we've got there, and I think if Professor Goodman were here today, he would be actually saying we shouldn't be focused on hypertension, we should be focused on excess and weight as the driver. He said that on a number of occasions. And if every day I go into the Chimes to walk past McDonald's at lunchtime, and it is heaving with young people, adults, and there's queues outside. Sometimes it sort of always reminds me of the challenges I think that we have. Okay, so I'm going to note the report. I think the action that we've got arising out of this one, Nikki, is to ask the Director of Public Health to develop a strategic excess weight programme as part of the health and wellbeing strategy and delivery plan.
Yep.
Thank you. Okay, thank you. I think, Sharon, we're moving on to agenda item 8. I think this is your agenda item 2 on the re-establishment of the Health Protection Committee.
Yes, thank you, Chair. This is quite a straightforward report in that Hillingdon in the past had a Health Protection Board that hasn't met for some time. So the proposal here is that we re-establish that group, but we call it a committee as opposed to a board. I'm not precious about the name of it, but this needs to be a doing group. We can't resolve health protection issues if all we do is sit around a table and talk about them. So this is really about establishing a group that will be chaired by myself as DPH that really starts to use the evidence that we've got, which Amanda, you alluded to earlier in terms of our vaccination uptake, our screening uptake. But we also have populations that are vulnerable to infectious disease, such as TB and other infectious diseases. But we also need, as a system, to be properly prepared to be able to respond to any emerging pathogen or any outbreak, or dare I say, the next pandemic. So obviously there is work that is going on at a pan-London level around emergency response plans. Hillingdon is working with Hounslow, for example, on joint opportunities for working together on health protection. There is a pan-London memorandum of understanding across Directors of Public Health and UK HSA, for example. But this is really about having a group that is focused on addressing the health protection risks that we have as a borough. The other proposal here, Chair, is that we change the governance arrangement slightly for this committee, and that actually the committee reports to the Health and Wellbeing Board, but it does that through an annual report. So while I think previously the governance arrangements was that the old Health Protection Board reported elsewhere, health protection is a statutory duty of the local authority, so really the Health Protection Group should report here, but through an annual report, unless obviously there are significant risks that need to be brought to the board in year. So as you can see, there are some draft terms of reference attached. There's a little bit more work to do, I think, in identifying the actual named individuals from the trust. So some further conversations to have around that. But it's here for the board to hopefully approve, Chair. Thank you.
Any comments? Tony?
Thank you. Really just to check constitutionally, because it's a statutory duty of the council. I know we just probably need to think about how we've cited that as being discharged through any other committees or anything. So it's more of an hour sort of governance issue to think about, but Nikki looks like she has an answer. So.
I have no answer right now, but yes, it is something we'll need to look into. If the board actually agrees to go ahead with this, then I don't know where it reported to previously.
I think it was stood up specifically because of COVID, and was more of an officer group, but still led within sort of public health. So I wonder whether we've captured it under the discharging of public health responsibilities, but it's a technicality we'll check up on. Yeah.
I just say in every other local authority I've worked in, it's reported to the Health and Wellbeing Board, because the Health and Wellbeing Board is a statutory subcommittee of the council. The duties are discharged through the Director of Public Health. That's one of the reasons you have a Director of Public Health, and then the reporting through the Health and Wellbeing Board. It's worked like that in every other local authority that I've worked in, so it seems to work quite well.
Okay, so let's just check this. So I think we are approving the establishment of the Health Protection Committee for Hillingdon. Recognise that we have some draft terms of reference and membership, which will be finessed post meeting, and we agreed to receive an annual health protection report. However, interim reports can be made in the instance of a particular issue that requires it to be done. And again, the membership, I think, will inevitably shift, I think, in some ways, and particularly in terms of ICB representation on future committees, but let's pick that up. Are people happy with that to approve that? Good. Okay. Now, I think we're now on to agenda, well, I know we're now on agenda item 9, which is the occupational therapy services update. So, who's doing this? We have neither the Children's Services Lead or the author. Can I would just say, I will defer it, but can I just express disappointment that we haven't got the lead officer here to present this report? Okay, we'll defer that to the next meeting. You're right, okay. So we have, I'm going to move us on to agenda item number 10, which I think, Nikki, you're going to take us through because it relates to, I think, an action from the Health and Social Care Committee. Yep.
Thank you, Chair. So the Health and Social Care Select Committee undertook a single meeting review of GP coverage in Hillingdon. This was undertaken at the meeting in July, and a report was then considered by Cabinet at its November meeting. The report was shared with Amanda prior to it actually going public, and I am aware that there are an awful lot of bits of work that have been going on already. To ensure that the recommendations are actioned, or the resolutions are actioned, it would be useful for the board to be able to monitor their implementation. So I would suggest that we have an update on the implementation of the resolutions considered by the board, perhaps every 6 months, but this will be down to the board. Thank you.
Generally, I just wonder, Sean, could we incorporate that into the performance report rather than do another separate report? I just wasn't exactly clear what some of the resolutions and actions were. Obviously, I don't think I came to that particular health screening committee. I'm not sure who the champions are. It refers to, and I just want to make sure that we are reporting in something which the Health and Social Care Committee recognised from its discussion. Amanda?
Yeah, so it was actually the last meeting that Eddie attended as CEO. However, there was a handover obviously between Eddie and I, so I absolutely am aware of the report. I think you're right though, Keith, some of the actions probably need crisping up slightly, because I was thinking, I think I know what that means, but I'd like to clarify. I think the champions refers to the fact that we've got 2 HIT-funded champion roles at the moment, a mental health one and a dementia role, one in the southwest, one in the north, which are doing some fantastic work, but obviously still relatively early days. They started earlier this year. So I think that's what that was about. Recognise what's being said about IT systems. That's quite a big challenge, but yes, it's absolutely on our agenda. And then on I actually can comment on the ones where it specifically says Confed Hillingdon to be asked to investigate the possibility of patients' use of online booking systems. So that's now. Online booking is now a requirement under the standard GP contract in hours, and has been in the contract since October, so that is actually a requirement anyway. As you may be aware from the press, that's caused quite a lot of hoo-ha, particularly with the BMA, but it is something that we have implemented, practices are doing locally. I'm not aware of any practices specifically not doing that, and we've not had, unlike some places, we haven't had sort of active campaigns encouraging GPs not to do that. So I think the one about convenient callback times, the telephony that most of our practices had, because it was something that we implemented as a if you like, a bulk purchase on behalf of a lot of practices a couple of years ago. The cloud telephony platform does allow for people to ask for callbacks. It's not used by absolutely every practice, and we collect data on this across all practices in Hillingdon, but probably 70% of practices are using that. I don't think you won't. In fact, I know you can't specify a callback time, but you can be asked for a callback. So I think that's underway, I'd want to say. And then in terms of equality to request to be seen by a same-sex medical professional, that is a requirement under the GP contract that you can request it. They can't be required to give it because it may not be medically safe if you need to be seen quickly and there just isn't someone available. But absolutely, it is a requirement that you can request it, and where it's possible, that will be afforded to you. So I don't think there's more that can be done about that, to be perfectly honest. It's something that already exists. So I'm not quite sure of the context of that request, though, to be honest. So yeah.
So I wonder, I do wonder, because I don't want Councillor Dennis to come back saying you haven't done what committee asked you to do. So I just wonder whether, is there a route for just to clarify, Nikki, what exactly is wanted here? Because I can see recommendation 1 is a bit like crystal ball gazing, and about where GPs are likely to be in 10 years time. We have an neighbourhood estate strategy which does some of that work, but not all of it. And then A, B and C on recommendation 2, I can see A would be covered by a digital strategy, Amanda, that we're talking now actively about. B, I think, is HIT funding, and it's subject to substantive funding being identified to roll that out anywhere. And then C, I think, and I would say that the engagement around our health and wellbeing strategy would cover C, because we are talking about the future of community neighbourhood care as part of that engagement piece. So maybe if we do that, if we just, I'm making it up as I go along, if we just say what we think that is, and then just ask Councillor Dennis if he could just say, yes, that's exactly what I'm looking for.
Chair, I'm happy to find clarification for you.
Will be really helpful. And given that we have our Health and Social Care Committee tomorrow evening, I think that will be helpful. Okay. So with that, we note the plans to bring the update, and we'll get clarification via Nikki at that what we are planning to do meets the requirements of the Health and Social Care Committee. Okay, I'm going to move us on to the last agenda item on this part of the meeting, which is the board planner and future agenda items, which is attached as Appendix 1 to agenda item 14. Comments from people, but I think, Nikki, what we've definitely added to that will be bringing back the health and wellbeing strategy for approval whenever the March meeting is adjusted. Is adjusted to, and can we also bring back, please, the OT paper that's been deferred from this meeting? Are there other ones that we want to add to the board plan that we know are coming up?
Just depending on when the meeting is in March, it will be the ICB configurations going forward for next year.
Yes, thank you. That's in fact that's absolutely correct. That will be the timeline for it. Yeah.